will start the recording.
Okay.
You're ready to go.
Hi, everybody. Thanks for joining. I'm Jill Wecht. I am a professor of medicine and rehabilitation medicine at Mount Sinai, and my primary position, though, is a research health scientist at the James J. Peters VA in the Bronx. So thanks for joining. I'll talk today about blood pressure disorders in people with spinal cord injury and some of the things that you might want to know. Okay. So it's important to understand that, not everybody with a spinal cord injury is going to have blood pressure problems. As more and more data are becoming available from the research side of things, we do understand that it's not exclusively in certain individuals, but that it is more likely to be in people with injuries above T6. But people with injuries below T6, even if they're very incomplete injuries, and some people that may even be ambulating, walking, may have blood pressure problems. And it's just important to understand who those people are and if they have blood pressure instability is what we call it. So although many people may have these disorders of blood pressure, a lot of them are not aware of it because they don't relate some of the common symptoms that they may be experiencing with blood pressure problems. But again, there's more and more evidence that does suggest that some of the symptoms that are commonly reported in people with spinal cord injury may be due to their blood pressure problems. And those symptoms and side effects include fatigue, depressed mood, washed out feeling, lack of motivation, feeling cold all the time, and having a cloudy mind. These are some of the things that we hear from people when we talk to them about blood pressure problems, that they that maybe feel better when they get their blood pressure problems treated. So this is an example of what blood pressure problems may look like. And this is an individual with C5, so Asia B injury, so very high level injury. And this is over a 24-hour period. So on the x-axis, we have time going from 0 to 22 and then 24 hours. And on the y-axis, on the left, we have blood pressure. And blood pressure is really this area of gray in between. The top would be your systolic blood pressure, and the bottom would reflect your diastolic blood pressure. And then the blue line is heart rate. So over a 24-hour period, you can see that blood pressure is very, very variable in this person, and that it relates to specific activities like a bowel routine or a transfer from the lying down position to a seated position, as well as some therapy that might cause increases in blood pressure. And obviously then, if the catheter becomes kinked when this person's asleep, he has surges in blood pressure. And what that means is that his systolic blood pressure ranged from 71 to 180 millimeters of mercury. So that's more than 100 millimeters of mercury change over a 24-hour period. And what's really important is that these changes occur very rapidly. So it's not like it rises slowly and then falls slowly, but you have rapid swings in blood pressure that are quite dangerous. And then we're going to talk a little bit more about autonomic dysreflexia, which this individual had 33 episodes of autonomic dysreflexia during the day, but unfortunately did not report symptoms of autonomic dysreflexia. And they also experienced 25 episodes of orthostatic hypotension. Again, they did not report symptoms of either of those blood pressure problems. So we're going to talk now about those two conditions. Orthostatic hypotension is on the left, that's in blue, and autonomic dysreflexia is on the right, and that's in red. I'm going to start with orthostatic hypotension in blue. It's in blue because orthostatic hypotension is a condition of low pressure, kind of like it's like a low end of the spectrum. And it's defined as a fall in systolic blood pressure of more than 20 millimeters mercury or more, or a fall in diastolic blood pressure of 10 millimeters of mercury or more, when someone is moved from a lying down position into a seated position or into a standing or tilted position. So in this graph on the top left, you can see that this individual is in the supine position, and then they're moved into the head up tilt position here. And blood pressure again is in gray. And you can see that as soon as this person assumes this upright position, blood pressure falls rapidly to a very low pressure here, and then is resumed repositioned into the supine position again, and blood pressure rises. And you have this heart rate response that corresponds to a fall in blood pressure. You'll have an increase in heart rate, and then vice versa. So on the left side of this graph, you see the brain at the top, and you see where the injury is down here at T5. So basically what happens is the brain can't get a signal down through the cord to say to the blood vessels constrict to maintain a higher level of blood pressure so that I can have good perfusion of the brain. And so you have a fall in blood pressure, a fall in cerebral perfusion, and that's where you might feel some of the symptoms that I'll go into in a moment. But then on the right-hand side of this graph, you have autonomic dysreflexia, which is a condition of high blood pressure. So it's red, it's intense. And you have a rise in systolic blood pressure of 20 millimeters of mercury or more with autonomic dysreflexia. And again, this is during everyday activities. In this graph here, blood pressure again is in the gray and heart rate is in the blue. You see elevations in systolic and diastolic blood pressure with this is a stimulation to retrieve sperm for reproductive purposes. So you can see that as they intend to extract the sperm, they use vibrostimulation, and there's increases in blood pressure. But what's really alarming is that over time, they did some more stimulation here, but at the end, the blood pressure is really excessively elevated to a systolic blood pressure of 300 millimeters of mercury or thereabouts. So it's very dangerous. And so it's the same thing with the injury being here, the brain can't control the vasculature as well as it would like. So when there's a stimuli below the level of injury, and this could be stimulation for sperm retrieval or a full bladder or a full bowel, the spinal cord below the level of injury knows that that's happening. The bladder's full, but the brain can't send signals down to either relieve the bladder and release the stimuli, or at least not allow for the blood pressure to get so high by relieving some of that vascular tone. So these two problems are really the result of an autonomic nervous system impairment. And there's two branches to the autonomic nervous system: the sympathetic branch, which is the fight or flight. So as soon as that gets activated, you get tense, you get frightened, or you get, you want to fly the scene, you want to do something to relieve whatever it is that's causing the pain or the fear, to get you to move, to get the stimuli to be, away from you so that you're not in danger, so to speak, or in pain. The other side is the parasympathetic nervous system, and that's the rest or digest. So these two branches of the autonomic nervous system work basically together to balance really every organ system in the body. We're talking about blood pressure here, but they work together to control not only blood pressure, but also heart rate. They work to control your bowel and your bladder movement. They work to control your breathing, your temperature regulation. So the autonomic nervous system is really controlling many of your body systems that you don't think about, that you just go about your everyday and let the autonomic nervous system do its part to keep you in balance, in homeostatic balance is what we call it. With the spinal cord injury, however, you have impairment of really the sympathetic side of things. So, and that can be classified as these three areas, and I'm going to go into it a little more detail, but we have the parasympathetic in the blue lines here, and we have the sympathetic system in the red lines, and it's a little hard to see, but what we're seeing here is that the parasympathetic nervous system exits the spinal cord above the cervical spine. It actually exits the basal ganglia, the base of the skull, and it innervates the heart. It does not innervate the blood vessels, but the parasympathetic nervous system can control blood pressure by regulating heart rate. And that, again, is not affected by a spinal cord injury because it exits above the spine. However, the sympathetic nervous system is affected by spinal cord injury, and it's differentially affected depending on the level of the lesion. So individuals with tetraplegia at C1 and T1 and above have descending interruption of this the brain control of the sympathetic nervous system. And the sympathetic nervous system innervates both the heart and the blood vessels. So when you have a cervical injury, the brain can't control blood pressure through the heart or through the blood vessel very well. Individuals with high paraplegia between T2 and T5 have some interruption of the sympathetic chain that innervates the blood vessels in the heart. So they have some ability to regulate blood pressure better, but it is somewhat interrupted. And individuals with injuries below T6, in general, have intact both sympathetic and parasympathetic control of the heart. However, they will have some impaired control of the vasculature to the splanchnic circulation, which is a very big vascular bed that controls a lot of the blood volume, and it's important for blood pressure regulation. And they also will have some impairment to the vasculature of the legs. So although they may have normal blood pressure more often than not, there are individuals with low-level paraplegia that might have blood pressure problems because of this impairment to the splanchnic and the lower extremity vasculature, or the blood vessels of the legs. So now I'll go into a little more detail about orthostatic hypotension. So orthostatic, the word means a change in position. For example, when you move from a lying down position to a sitting up position. And hypotension means low blood pressure. So put them together and they mean low blood pressure when you move from a lying down to a sitting or a standing position. And the reason why orthostatic hypotension occurs is because gravity pulls things down. So when you see and you drop a book, it falls to the ground immediately. Well, the same thing happens inside your body. As you stand up, gravity pulls everything down. So when you're in the lying down position, your blood volume is equally distributed throughout your whole body. But as soon as you sit up, gravity pulls that blood down and it pools to wherever the lowest point in your body is. So if you're standing up, you can imagine that it would be in your foot and in your lower extremity. When you're seated, it's all along your legs and your butt. So what happens is when the blood is no longer in your heart, it can't go to your head, and your head becomes hypoperfused is the word we use. It basically has low blood pressure, low blood flow. So when that happens, your brain normally would say to your blood vessels, hey, you're standing up now, I need more blood. And then it would send a signal down your spinal cord, and that signal would get to your blood vessels, and the blood vessels would constrict. And as they constrict, they would increase pressure and increase blood flow to the brain. So the brain would be well perfused and you wouldn't have any problems with dizziness. However, with the spinal cord injury, the brain still feels like, I don't have enough pressure, I don't have enough blood flow. Can you please constrict so I can get more blood pressure and blood flow? But the spinal cord injury doesn't allow that signal to come down, so the blood vessels can't hear that command from the brain. So what happens is you stand up and you get dizzy. And other symptoms that are common but not always reported would be lightheadedness or blurry vision, nausea, ringing in the ears. Sometimes you would get a strain in the neck and the shoulders. Coat hanger syndrome is what it's called. And there's other symptoms that you may be experiencing due to low blood pressure that are unique to you. We've come up with a lot of different ways of having people explain what it means for them to have low blood pressure. But those are the common ones. So if this happens, if this communication is impaired, you may feel dizzy, you may be confused, and you may even faint. And what happens over time, unfortunately, is that two things. One is that you become used to it and you don't feel dizzy anymore. You don't recognize that you feel dizzy anymore, or it can get worse over time. As people age, with or without a spinal cord injury, we tend to have diminished or lessened autonomic bounce is what I call it. The autonomic nervous system ages too, and it becomes less able to control blood pressure as well as it did when we were young. So as we age, it may get worse over time, and symptoms may develop just simply because we're getting older and we're less able to maintain good blood pressure when we move around during the day. So I have two testimonies from individuals with spinal cord injury that I'll read to you because they offer the spectrum of people and how blood pressure may be affecting their lives. I am a C4, C5 Asia A quadriplegic. One of the biggest obstacles in my life has been my blood pressure. My blood pressure is low. It stays at 60/38 for most of the day. And most people, they would be passing out, and she was passing out 5 or 6 times a day and having to have constant care because of worry. I had to drive around in my chair with a sign on my back that said, push this button if you find this girl passed out in her chair. My low blood pressure impacted my mood. My energy levels were low. I was tired all the time. When you're tired all the time, you don't do much of anything. So obviously this person is very impaired due to her blood pressure. On the other hand, this person was not. I'm hoping you will also suggest that newly injured higher level SCIs, individuals with SCIs, be given blood pressure cuffs or advised when being discharged home so they can check their blood pressure. Over the years post-injury, I now feel I was needlessly dealing with that washed out feeling we discussed for many years without realizing it may be from low blood pressure. My pressure was never low enough to pass out, just low enough to feel like crud. So these are two ends of the spectrum that may be, implicated in when you have orthostatic hypotension. Just something to think about. So now the other side of the coin, autonomic dysreflexia. When you or your body experience something painful or some stimuli, the sympathetic nervous system kicks into gear so that you either stay and you fight that thing, whatever it is, or you take flight. So that's that saber-toothed tiger, right? So that's the sympathetic nervous system. You don't have to think about it. That tiger comes at you and you're moving. You're either fighting that tiger or you're running, right? But in normal circumstances, your brain controls that. It activates the parasympathetic nervous system in balance so that you can respond in a good way rather than overreacting. And what we have with autonomic dysreflexia is basically untethered sympathetic fight or flight without that balanced activation of the parasympathetic nervous system. So because of the injury, the balance between these two branches is disrupted. So what happens when you have something occur below the level of injury, like a full bladder or a full bowel, is that above the injury, your brain is able to control the vasculature well. So you have increased in sweating, you have increased face flushing because your blood vessels are open up, your heart rate may be increased or decreased, you're sweating a lot, you may have a headache, your neck veins may be distended. But below the level of injury, you have vasoconstriction. You have a pale, cool, no sweating occurring because the signal from the brain can't get down to alleviate that onslaught of sympathetic, basically vasoconstriction to the vasculature below the level of injury. So some of the things that trigger autonomic dysreflexia would be tight clothing, a belt, a shoe, a sock, a full bladder or bowel, as I mentioned before. Also pressure ulcers. I'm sure your doctor has told you that when you're seated for long periods of time in the chair, you may develop some pressure wounds or even just pressure points. So you should move around as much as you can in your chair. And again, you have this difference between what's happening above the level of injury and what's happening below the level of injury. So some of the common signs and symptoms of autonomic dysreflexia, the sign is that you have an increase in blood pressure of greater than 20 to 30 above your normal blood pressure, and you may start sweating profusely. In addition, you may have a pounding headache, and you may feel flushed in the face. You may have tightness in the chest or a stuffy nose, and you may experience blurred vision. These slides are blurry. These pictures are blurry, so it's not autonomic dysreflexia here, just for those of you who are worried. So while both autonomic dysreflexia and orthostatic hypotension may be symptomatic, we do recognize that many, if not most individuals, may be experiencing these blood pressure disorders throughout the day without knowing it. In fact, more and more evidence comes to light to suggest that really silent AD and asymptomatic orthostatic hypotension are highly common in the spinal cord population. So what can we do? Well, the first step is to understand your blood pressure. It's to take your blood pressure many times throughout the day, to identify with how your blood pressure behaves when you go about your everyday activities. It's also important to understand that simply taking your blood pressure once or twice in the doctor's office really is not enough. You can have a normal blood pressure while you're in the office, but if you monitor it throughout your activities of daily living, you'll see that there might be differences that you're not aware of while you're seated at rest calmly with your doctor. So you can ask your doctor about 24-hour blood pressure monitoring. It's not common practice now, but it is something that we are trying to get more, clinical environment more aware of. It's not totally convenient, but it's not totally inconvenient. You wear, like you would wear a harness around your neck, or you can wear it on your belt. And the cuff inflates basically, you can set it to inflate at different intervals, but we try to have it every 20 minutes while you're active during your day, and every 30 minutes at night, so that you're not disturbed as frequently during your sleep. So if you do this, if you do 24-hour monitoring and you find out that you actually do have a lot of blood pressure disorders, these ups and downs, but you're not feeling any symptoms, is there a problem, right? So if you're not feeling anything, why is it a problem? Well, it's important to understand that it may be that you don't experience it. It may be something like you've just been so used to it so long. You've been in the chair for a long time, and this is just how your life is. So before we make that decision of whether or not this is a problem for you, you should pay attention to certain feelings that you might be experiencing throughout the day. Like in the morning when you sit up, do you feel lightheaded? Do you feel just weak? Do you not want to move into the chair and get on with the day? Shortly after you eat a meal, are you really lethargic? Do you get sleepy and maybe take a nap more often than you'd like to? Are you able and willing and excited to, engage in physical exercise or any kind of outdoor activity recreationally? During your bowel routine, do you feel okay? Do you have a headache? Do you get the sweaty, goosebumpy feelings when your bladder is full and when it's empty? Do you feel a change in anything, any emotion or any subjective feeling? And then you want to ask yourself if you feel energetic or tired, how often you feel motivated, how happy or sad or alert or sleepy, because we have noticed that not only does it affect obviously your heart and your blood vessels and your brain, but it also affects your mood and how energized you are and how motivated you are. So if we can help with that, because we recognize that this is due to blood pressure, we would like as clinicians to help you in any way we can. So if you find in step 1 that you do have the problems, blood pressure problems, and in step 2 that you may be feeling some of these ill effects on your life every day, you can try these modifications, which would be to sit up more slowly. Anytime you change positions, just do it a little more slowly. Eat smaller meals more frequently throughout the day rather than, at 3 meal times per day. Drink plenty of water, increase your salt intake, and empty your bladder and bowel as frequently as you possibly can. And again, monitor these feelings while you're making these changes to see if you notice any difference in your energy level, in your alertness, in your motivation. The problem is that when you treat one of these blood pressure disorders, like orthostatic hypotension, you may be worsening autonomic dysreflexia. So I'll go into some of those conditions now. So orthostatic hypotension is, again, when we move from a position of lying down to seated or to standing, blood pressure falls. So what you do in that situation is you take yourself back down to the position where you were originally. So if you were lying down and you sat up too quickly and you got dizzy, lie back down. And you'll feel better immediately, and then recognize, just move up to the seated position a little more slowly. However, the other side of the coin is if you have autonomic dysreflexia and you're lying down, you need to sit up to change that orthostatic position so that you have less sympathetic charge, whatever you can, and you would lower the blood pressure. Now, obviously, one condition you want to lie down, the other you want to sit up. So it's it's what do you do in this circumstance? And it's something that you and your doctor really should talk about a little more closely, a little more in a little more detail. So if you make these modifications and they don't seem to be working, do talk to your doctor about potentially looking into other interventions. Like for orthostatic hypotension, you can use compression garments You can use medications, or you can use electrical stimulation of the spinal cord. And I'll go into a little bit of detail in a moment about the electrical stimulation. And autonomic dysreflexia, you can loosen tight clothing. You can remove the stimulus that's causing the autonomic dysreflexia or the high blood pressure. And you can use medications to treat the high blood pressure. But we have to recognize that these may be, again, working against one another. So the compression garments will apply pressure to the abdomen or the leg to improve your blood pressure, but they may increase the likelihood or the intensity of autonomic dysreflexia, which is to then loosen your tight clothing and remove your compression garments. So treating orthostatic hypotension, again, they worsen autonomic dysreflexia. So what do you do in that instance? Talk to your doctor. And then medications that increase blood pressure, the common ones would be Minidrin, fludrocortisone, or droxidopa. Increase your blood pressure. On the other side of the coin, the medications to treat autonomic dysreflexia lower your blood pressure: nitroglycerin, nifedipine, prazosin, and Botox. But again, those that increase your blood pressure will worsen AD. Those that lower your blood pressure may worsen OH. So you're back into the conundrum of what do you do? How do you treat these disorders of blood pressure when they're really on both ends of the spectrum? Well, this is where electrical stimulation of the spinal cord comes in. And I'm not making a pitch here, but if you're following any of this work, it's really very, very exciting. Because again, getting back to the initial point, that blood pressure problems in people with spinal cord injury is the result of impaired autonomic nervous system function. So it's not simply treating high blood pressure or treating low blood pressure, it's treating the underlying autonomic impairment. And that's what we believe electrical stimulation is doing. Emerging evidence suggests that depending on the spinal stimulation parameters that are used, you may restore the underlying autonomic deficit to restore the balance between the sympathetic and the parasympathetic nervous systems. You're basically allowing your intrinsic mechanisms to work again, to control your blood pressure. And I'm focusing on blood pressure here today, but really it can control a lot of your other organ systems as well. Bladder function is being studied at length, as well as some temperature regulation and respiratory, pulmonary, lung effects. But the blood pressure effects are really interesting, and I'll go into a little bit of science here for a moment. So in panel A, we have an individual with spinal cord injury, and these are all high level, above T3, motor complete, Asia B individuals. So in panel A, we have an individual with T3, Asia B, spinal cord injury. When this person is moved from a seated to a standing position, their blood pressure is pretty well maintained. So we would say that this individual probably has a pretty intact autonomic nervous system, at least that's controlling the cardiovascular system or blood pressure. However, in panel B, we have an individual who clearly has an autonomic impairment, because when this individual is moved from the seated to the standing position, you see blood pressure in gray is nice and normal when this person's seated, but as soon as they're put in the standing position, they have a precipitous fall in blood pressure, and this individual then can't maintain a standing upright position. So epidural stimulation is implanted in the lumbar sacral spine, basically outside of the spinal column, just below the dura of the spine, and the configuration can be used to maintain blood pressure. So this individual is the same person in panel B, but when the epidural stimulator is turned on, and this is the configuration that's used for this individual, you see that when this individual then is moved from the seated to the standing position, there's no fall in blood pressure. So it's important to understand that we're not just increasing blood pressure like you would with Minidrin, and we're not just lowering blood pressure like you would with nifedipine, we're actually regulating blood pressure, and that's an important concept. So after that study, these investigators at Louisville, in the University of Louisville, looked to see if they could use a parameter to not only just stop the fall in blood pressure when people are moved from a lying down position to a seated up position, but if they could use it to really stabilize a more normal blood pressure. So This is another individual who has low blood pressure while they're seated with the stimulation off. But as soon as they turn the stimulation on, and again, they use specific parameters, they can raise blood pressure and they can maintain a nice steady blood pressure over a 70-minute period. So this gives us the idea that, again, we're not just raising or lowering blood pressure, but we're regulating blood pressure and we're maintaining normal blood pressure intrinsically using homeostatic balance between the sympathetic and the parasympathetic nervous systems. And then finally, for the spinal cord stimulation studies, this is work that suggests really clearly that we are improving intrinsic mechanisms of blood pressure control. So I'll take you through this. It's a little bit complicated, but in panel A in the upper left, we have an individual who's moved from the supine to the seated position. And this individual experiences a fall in systolic blood pressure, which is the blue dots, a fall in diastolic blood pressure, which is the yellow dots, and a rise in heart rate. So this individual has orthostatic hypotension and is very, very symptomatic when their blood pressure falls by more than 50 millimeters of mercury, I should say. So this is a very significant fall in blood pressure. So in panel B is the same person, but now with the stimulation, epidural stimulation turned on. And so you can see that when this stimulation is turned on at these specific configuration parameters, blood pressure, systolic in blue, diastolic in yellow, and heart rate in gray are maintained better when they're moved from the supine to the seated position. And what's really interesting is that this individual used these stimulation parameters at home for 80 days. So this is surgically implanted into the lower back. And this individual then used this stimulation over 80 days at home. And then they came back in and they were tested again with this sit up. They were put in the supine position and they were raised to the seated position. And you can see that heart rate and blood pressure did not change when this individual was put into the seated position. And what's really interesting is that there was no stimulation used here. So this suggests that using this epidural stimulation targeted for blood pressure, we're restoring the underlying autonomic impairment to re-regulate intrinsically blood pressure, which is really great. And that was then replicated by another group who showed very similar findings. This is one individual with orthostatic hypotension without the stimulation, blood pressure falls. Then a sham stimulation, so this is not targeted for blood pressure and there's no effect on improving blood pressure. But when the stimulation parameters are specifically targeted to maintain blood pressure, you can see that blood pressure rises back up during this head up tilt maneuver. And that has implication for cerebral blood flow. So cerebral blood flow goes up when blood pressure goes up, and also cardiac contractility, the ability of the myocardium, the muscles of your heart to function, is also improved with these stimulations. And finally, they looked at parameters of cognitive function, and they found that when they used the blood pressure targeted stimulation parameters, they had an improvement in cognitive flexibility, the ability of the person to execute multiple cognitive tasks at one time. So that's all implanted spinal cord stimulation. We're looking at the use of non-invasive, so transcutaneous electrodes placed on the skin aimed at the spinal cord to regulate blood pressure. And we're starting a study in the Bronx this summer at the VA, and we're starting to enroll people. Basically, we put electrodes on the back of the neck and we use current that we regulate with these external devices. And prior work has suggested that with specifically targeted configuration, that would be the amount of current that's used, the frequency of the signal, as well as the pulse width between administration of the current. You can increase and maintain blood pressure in the seated position with this non-invasive spinal cord stimulation. And this study suggests that you can increase blood pressure, You also have improvements in cerebral blood flow, that's blood flow to the brain. And you have improved cardiac function. You have improved, again, heart muscle contraction. And that's with electrodes placed at the T7, T8 vertebral level. And this down here just shows you that there's no muscle activity. So it's not because we're stimulating the skeletal muscles and causing contraction of the muscles that increase blood pressure. This is actually targeting the autonomic nervous system to restore intrinsic balance between the sympathetic and the parasympathetic nervous systems. So just to recap, blood pressure disorders in people with SCI, what do you need to know? Again, not everybody with spinal cord injury has blood pressure problems. Many individuals, though, who do have blood pressure problems aren't really aware that they have these wide fluctuations in blood pressure because they don't have symptoms, the common symptoms. So understanding your blood pressure is important. So asking your doctor if maybe you can look at more frequent blood pressure monitoring, whether it's 24 hours, so you get multiple blood pressures over every hour throughout the day, and also so that you can get your blood pressure while you're doing your routine activities. Or if it's just periodic, you just take your blood pressure every hour or every 2 hours and just see if you can identify patterns of whether you have very stable blood pressure or very different blood pressure all over the place. But understanding that just because you don't experience some of the common symptoms like dizziness, lightheadedness, or a pounding headache, or goosebumps during your bowel care, or when your bladder's full, doesn't mean that your blood pressure is perfectly stable. And it doesn't have to be perfectly stable, but it just shouldn't be so wildly erratic as I showed in that earlier slide. So recognizing that some of the common symptoms that you might be feeling, like fatigue, depressed mood, washout, lack of motivation, feeling cold and a cloudy mind, might be due to a blood pressure issue that you just haven't recognized. And if we can treat that blood pressure issue, you might feel better and go about your everyday with more motivation, with more vigor, with more energy, and just, it may be able to treat more common symptoms than just dizziness, lightheadedness, and so on. So that's all I'm going to say. If there are any questions, I'm happy to answer them right now. Okay, so T4 para. At doctor's appointment, my blood pressure is usually in the low 120s over 60s. They always say good blood pressure looks good. Can I know if my blood pressure is good just from my injury? Would monitoring throughout the day, as maybe hourly, might give me a better idea? Yeah, so I think the answer is yes. That's the thing. You go to the doctor's office, and 120 over 60, there's no argument there that that's a solidly good blood pressure. But with an injury at T4, you might not know that during the day there are swings in blood pressure that might be managed with not with medication, not clinically, not needing medication, but just by doing things slightly different. And the reason why that's important is because if your blood pressure does swing a lot, again, it might affect some of the mood and cognitive abilities that I mentioned before, but also because it's very hard on the vasculature to have wild swings in blood pressure. So you might want to just take a look and see what your blood pressure is during your normal activities, and see if it's associated with any other symptoms that you might not be connecting the dots with. Okay, how could someone get enrolled in either the epidural trial or one at the VA? So I can, I should have put my contact information. You can contact us at the VA. You don't want to call. Why don't I give Ariane my email address, and you can contact me. The VA study will start this summer. It is enrolling people with cervical injury, and there are strict criteria. And the reason is we're really targeting hand function, but part of that is going to be to look at autonomic nervous system changes. So if you're interested in the study, I will give Ariane my contact information, and you can get in touch with us and see if you'd be appropriate for those studies. And that's it. Any other questions? So thank you for the presentation. Could exercise and diet help improve blood pressure? I know exercise and diet is generally good for everyone, but it would be especially good for people with SCI. Yes, that's absolutely true. Exercise and diet is always a good option. Yes, and we would encourage people to do that. It is also something to think about that exercising with your lower extremity is moves a lot more blood than exercising with your upper extremity only. And that's not to say that exercise isn't good. It's just in terms of a cardiovascular stimulus, it may not be as effective, but that's not to say that you shouldn't try that route first. Of course, anytime you can try some behavioral modification to improve, whether it's blood pressure or heart rate or any, pulmonary conditions, you should try it. But I think getting an understanding of what your blood pressure looks like every day, I think would be really additional importance. Oh, yes, thank you, Ariane. That's my contact. It's in the chat. Well, so certain foods will affect your blood pressure. If you do eat high salty foods, it may work autonomic dysreflexia, but it may benefit your orthostatic hypotension. So again, there's a balance there that has to be met. You have to understand that simply eating, a high salty diet or something like that would have benefits, but also detriments. So generally, if you eat more, whole foods, like less processed foods, it's better for your blood pressure. But in this case of a spinal cord injury, because of the autonomic impairment, it's less of I guess it's less of an impact, the food that you eat. It can't make up for the deficits of autonomic function. Any other questions? Okay, well, now that you have my email, if you have any questions that you didn't raise that you want to, ask me about, please don't hesitate to contact me. We do have a lab at Mount Sinai on KCC2. We're predominantly looking in the newly injured population, but we're available if you're there and you want to stop by and see some of our equipment and talk to some of the staff. You're welcome to come by. Otherwise, contact me, and I'm happy to answer any questions at any time. That's it. Thank you.
Thank you all.
Thank you. Bye, everybody.